You or someone you know has lost a pregnancy before, you unfortunately know all too well how terrible of a situation this can be, and also how hard it can be to find answers to those seemingly infinite number of questions you can be left with.
Yeah. So with that, we are actually going to take the next 2 episodes to cover stillbirth. This episode is going to share the causes and risk factors of late pregnancy loss or stillbirth. And then next week, we are going to share what investigations or workup can be done if you have experienced a stillbirth, some strategies for prevention, as well as kind of planning and thinking about another pregnancy after a stillbirth. In case this is your first time meeting us, I'm Sarah. I'm a board-certified OBGYN.
I'm Kurt. I'm a board-certified pediatrician.
And
we are the Doctors Bjorkman.
Welcome back. This is an extremely tough episode, and it may be triggering for those of you that have had a pregnancy loss, a stillbirth, or an infant loss. It also could cause anxiety for some of you who are currently pregnant. So please pause or skip this episode if you need to.
Yeah. We also know that after stillbirth, you may have many, many questions about what happened, why, and the next steps.
Right. You may not be ready for this episode right now, but as always, we want to provide you with evidence-based information so you can be informed when you're ready and you need it.
Yeah. Today, we're going to talk about the data that exists around stillbirth, how often it occurs, risk factors, and why stillbirth happens. As we mentioned, we're going to cover the maternal fetal workup, prevention strategies, and timing of next pregnancy in next week's episode. We've also previously talked about miscarriages, which are early pregnancy losses, in a prior episode that we'll link here. To start out, we need to first talk about what exactly is a stillbirth.
So the term stillbirth generally refers to the death or loss of a fetus at 20 weeks or more of gestation, and then sometime before or during birth. This can be further classified as early stillbirth, so 20 to 27 weeks, late stillbirth, 28 to 36 weeks, and then term stillbirth, which is 37 weeks and beyond.
The World Health Organization, or WHO, defines stillbirth slightly differently as being a newborn greater than 28 weeks of gestation with no signs of life at birth.
The categories of stillbirth I mentioned used in the United States, so early, late, and term, allow for comparison with some international data that's limited to those fetal losses 28 weeks or beyond. They also allow us to separate consideration of stillbirths that occur early and are potentially very difficult to prevent with any intervention from those that are late and potentially preventable by delivering the baby early.
In our video about miscarriage, we shared how pregnancy losses in the first 20 weeks actually occur in up to 1 in 4 pregnancies, with most of those losses actually happening very early in the first trimester. But how common are stillbirths or pregnancy losses later in pregnancy?
Right. So fortunately, the stillbirth rate has been falling worldwide. In 2000, there were 21.4 deaths per 1,000 births at greater than 28 weeks or beyond of pregnancy. So that's about 2%. By 2019, this rate had dropped to 13.9 deaths per 1,000 births, or about 1.4%.
And this worldwide reduction has been associated with improved access to and utilization of pregnancy care, skilled birth attendants, and an increased attention to known maternal risk factors for stillbirth.
When it comes to rates here in the United States, it is really important to stress that stillbirth is very rare, but still very devastating. The estimated rate of pregnancy loss or fetal death in the United States is well less than a quarter as common as it is compared to the worldwide rates. The definition of stillbirth in the US is again different from the WHO for worldwide rates. So for all US births, stillbirth occurs in less than 6 per 1,000 births after 20 weeks of gestation, or 0.6%, or 1 in 165. The most recent CDC data from 2020 reports a little more than half of those losses occur between 20 and 27 weeks, making the rate of stillbirth after 27 weeks about 2.8 per 1,000 or 0.3%. And when you compare that to worldwide for that age is about 1.4%.
Yeah. Now, I do need to mention that comparing incidence rates can be really challenging for many reasons, with one of the most challenging being that stillbirths are defined differently in different ways in various countries. They may be defined by different gestational ages or even just by weight at time of birth in some regions. There are also missing data from many countries and factors such as early termination that may occur in countries with easier access to some early prenatal testing that could detect a likely fetal anomaly or chromosomal abnormality that then for those pregnancies would be a reason for early termination before a time when that fetal death would be considered a stillbirth.
Stillbirth is the end result of a variety of maternal, fetal, and placental disorders which can interact to contribute to fetal demise. As Kurt just mentioned, this is difficult to study, but we want to share with you some of the available data.
Yeah. Now, causes of stillbirth differ between low and high income countries and also between early and late gestation.
Yeah.
In low income countries, things like obstructed or prolonged labor, preeclampsia, and infection have been reported as the most common causes of stillbirth. In contrast to that, high-income countries have major factors being things like congenital anatomic or chromosomal abnormalities, placental problems associated with growth restriction, and maternal medical diseases, as these appear to be the most common causes of stillbirth.
Right. So it's pretty easy to imagine that the lower rates of stillbirth in countries like the United States are largely due to increased access to care with the ability to more easily prevent or detect and treat things like infection, prolonged or obstructed labor, and preeclampsia that are those more common causes in low-income countries.
When thinking about early versus late gestational losses, those early gestational fetal mortality appears to be related to things like congenital anomalies, infections, growth restriction, and underlying maternal medical conditions.
Whereas when we think about late gestational fetal mortality, it appears to be due both to maternal medical disorders as well as obstetric disorders that generally evolve around the time of birth, such as placental abruption, placenta previa, cord prolapse, and other labor and delivery complications, as well as unexplained causes of stillbirth.
Now, unfortunately, despite our current levels of investigation in developed countries, the cause of stillbirth is often still left unexplained, with anywhere from 25 to 60% of stillbirths left unexplained. And this is looking at studies in the US, Canada, and Norway.
What can make these deaths feel even more tragic is that those stillbirths near term are more likely to be unexplained than stillbirths occurring early in gestation. In one study, up to 2/3 of unexplained fetal deaths occurred after 35 weeks of gestation.
Yeah, and for us, like, we know how much we would long for closure and answers when something like this happens.
As your physician, as your OBGYN, and for our patients, you just want an answer for why something so terrible happened. So if you have experienced this loss or an unexplained stillbirth, you have our hearts.
The most common known cause of stillbirth are congenital anomalies or birth defects, which are believed to be the cause of stillbirth in about 1 in 5 stillbirths.
Importantly, this rate varies from country to country and is greatly influenced by the availability of prenatal diagnosis via ultrasound, as well as the availability of pregnancy termination. We can't always be clear on if a major malformation found after the fact was the true cause of death, but it is considered the cause of death if that anomaly is rarely found in live-born babies, if babies with that anomaly often die, as well as is there kind of what we call biologic plausibility that could cause death.
Yeah. Now, by far the most common anomalies that lead to stillbirth include failure of normal brain development. This is things like anencephaly, holoprosencephaly, and then these are followed by things with abnormal heart development, like hypoplastic left heart, single ventricle patients, truncus arteriosus, and then finally by abnormal development of the gut or GI tract, things like congenital diaphragmatic hernia or omphalocele.
The second most common explained cause of stillbirth is the death of a growth-restricted fetus, or IUGR, intrauterine growth restriction.
Yeah. Now, this is often due to the placenta not working correctly or placental dysfunction, and is the presumed cause of both growth restriction and stillbirth. This dysfunction can be related to maternal blood vessel issues or placental disease, and many other things like smoking, drug use, infection, or preeclampsia.
Right. Another common cause of stillbirth is infection. Infection accounts for approximately 50% of stillbirths in low and middle income countries and about 10 to 25% of stillbirths in high income countries. Infection may cause fetal demise because of severe systemic maternal illness, so terrible pneumonia, severe COVID-19 infection, terrible influenza. Infection can also cause placental dysfunction because that placenta is infected. Example is malaria. Or you can have fetal systemic illness where the fetus gets very sick with infections like E. coli, group B strep, CMV, or even Zika virus.
Now, most studies report that infection is the cause of more preterm than term stillbirths. In high-income countries, the majority of stillbirths related to infection occur in fetuses in that periviable time period, which is 20 to 23 weeks of gestation, following something called PPROM, or premature preterm rupture of membranes.
Another cause of stillbirth is major genetic abnormalities. So most aneuploidies, or chromosomal abnormalities, are lethal in utero. Some aneuploidies, such as trisomy 21, 18, 13, and monosomy X, are compatible with life, but do have an increased risk of fetal demise. Although death of a chromosomally abnormal embryo or fetus is most common in the first trimester, so approximately 50% of all cases of early pregnancy loss are actually due to fetal chromosomal abnormalities, that loss can occur at any stage of pregnancy.
Yeah. In one study that looked at the genetic makeup of 823 stillbirths and neonatal deaths, 6.3% had a major chromosomal abnormality. And the most common abnormalities here were the trisomies 18, 13, and 21, in addition to sex chromosome aneuploidy, and then also unbalanced translocations.
Yeah. Additionally, the combination of a congenital anomaly in stillbirth increases the likelihood that the fetus had a chromosomal abnormality. In another study of 750 stillbirths, chromosomal abnormalities were found in 38% of stillborns that had an anomaly versus 4.5% of stillborns that did not have an anomaly.
Other causes of stillbirth include something called hydrops fetalis, which can be due to immune or non-immune etiologies. There can also be fetal arrhythmias or irregular cardiac rhythms. Something like unrecognized long QT syndrome could be the cause of stillbirth.
So some other causes we kind of think about that occur around the time of birth. For example, one is called placental abruption. An abruption is when the placenta starts to separate from the uterus before it is supposed to, and then that causes a lot of bleeding. Risk of abruption increases due to abdominal trauma, multiple pregnancy, high blood pressure, cocaine, or other drug use. Abruptions occur in approximately 1% of pregnancies, but account for between 10 and 20% of all stillbirths.
Umbilical cord abnormalities can also be linked to stillbirth. These complications could be things like entrapment, a nuchal cord, knot, torsion, stricture, or prolapse of the cord. And these have been cited as causes of death.
So that being said, it's important to note that nuchal cords, so a cord around the baby's neck, and knots in the cord are relatively common occurrences. They occur in 15 to 34% of pregnancies at term. And vascular constriction severe enough to kill a fetus is rare, very rare.
Issues with the placenta that we've talked about before with IUGR can also lead to stillbirth. And this can be from many various reasons as well. Things like abruption, a ruptured vasa previa, infection, cancer, structural or vascular malformations, vasculopathy, or infarction. Many of these can also be linked to IUGR, as we've already mentioned, and not necessarily lead to fetal death.
So finally, fetal maternal hemorrhage is another known cause of stillbirth. So fetal maternal hemorrhage is when a significant bleeding or hemorrhage from baby circulation passes to mom. Fetal maternal hemorrhage large enough to cause fetal death has been reported in up to 5% of stillborns. Usually there is no identified cause, but some case reports have described associations with placental abruptions, with vasa previa, with some cancers of the placenta, maternal trauma, external cephalic version, as well as amniocentesis.
Now, we've already shared a lot of data with you to this point about rates of stillbirth and then some of those potential causes that could maybe give you answers to why, but also hopefully help you plan for a future pregnancy if you wanted.
But we also thought it was important to cover risk factors for stillbirth to help you know if you might be at an increased risk or if there's any reason for increased medical surveillance of your pregnancy.
Yeah. To think about risk factors for stillbirth, we're going to break it down into maternal factors and then fetal factors.
As we have talked about the very low rates of stillbirth in the United States, we do need to point out that the rates within the United States can vary quite a bit based on maternal factors such as age and race. Certain races are at much higher risk of stillbirth, as are very, very young moms and significantly older moms.
Yeah. From that 2020 data, the fetal mortality rate was highest in races of non-Hispanic Native Hawaiians and other Pacific Islanders, and then also non-Hispanic Black women. The rates were lowest in non-Hispanic Asian women. Fetal mortality rates were highest for moms whose ages were under 15 years of age or those who were 45 years of age and older. Other big risk factors that were seen in this study were women who smoked during pregnancy and for women with multiple gestation pregnancies.
Yes. There are also prior medical conditions that increase your risk of stillbirth. These are things like diabetes, hypertension, substance abuse, clotting disorders, lupus, chronic kidney disease, hypo or hyperthyroidism, and sleep disordered breathing.
Yep. Other medical conditions to note are things like uterine anomalies.
Yep.
Uterine rupture, for instance, is a rare but devastating cause of stillbirth. There's also structural uterine anomalies and something called amniotic band sequence that usually causes fetal deformation, but can result in stillbirth if that umbilical cord is constricted by a band.
The other thing sometimes talked about as an increased risk of stillbirth is something called intrahepatic cholestasis of pregnancy, or just cholestasis. So cholestasis causes itching. Often the symptoms are itching of your palms and soles of your feet. Typically in late second trimester, early third trimester, and basically bile acids in your body are elevated, and liver function tests are often elevated in mom as well. And this confers an increased risk of stillbirth because it's thought that those bile acids can build up in the baby's system. A special maternal risk factor is also assisted reproductive technology, which includes primarily IVF or in vitro fertilization. When looking at pregnancies conceived from assisted reproductive technology, stillbirth rates appear to be slightly increased in pregnancies that, again, were conceived via IVF. A meta-analysis of 33 cohort studies found that the baseline risk of stillbirth in singleton gestation following IVF was about 4.4 per 1,000 total live births. When they did some more analysis of this, kind of some subgroup analysis, they did not find an increased risk seen between women who did IVF and had infertility versus those with subfertility, which suggests that maybe the risk factor is actually infertility itself and not the IVF treatment. But again, this is something that's really difficult to study and tease out.
Now, there are also multiple fetal factors that are associated with stillbirth.
One of those things is multiple gestation. Fetal mortality increases with the increasing number of fetuses. So the risk of stillbirth is 2.5 times higher for twins than it is with singletons, and it is 5 times higher for triplets or more.
Yeah. Fetal male sex is also a risk factor, with stillbirth being more common in males than females. There's actually a systematic review of this that showed that rates for stillbirth in males was 6.23 per thousand births, whereas it was only 5.74 per thousand births in females.
Another risk factor for stillbirth is post-term pregnancy. So the perinatal mortality rate at 42 weeks or beyond of gestation is twice the rate that it is at term, and it increases. That stillbirth rate at 43 weeks and beyond is 4 times what it is at term, and then it is 5 to 7 times greater risk of stillbirth at 44 weeks.
Yeah, the absolute rate here is estimated somewhere between 14 and 40 per thousand live births, or 1.4 to 4%.
Yeah. So this is why your OB provider is going to start talking to you about induction of labor if your pregnancy goes much past your due date, because that risk of stillbirth is just increasing as you go weeks beyond your due date.
Yeah. So we know this was a very intense episode.
A lot.
If you've made it this far, you've listened to a lot of information, but as always, we really wanted to just provide you with evidence-based information that was hopefully easy to understand, albeit in a pretty large volume this week.
Yeah.
If you've experienced a stillbirth, a miscarriage, or infant loss, please know that our hearts go out to you, and we cannot imagine your grief.
Yeah. Next week, we are going to be talking about the workup if you have experienced a stillbirth, as well as prevention strategies, and then kind of what the data says about the timing of pregnancy after a stillbirth.
Yeah, so with that, please make sure you're subscribed so you can catch that episode next week. If you're also wondering about early pregnancy loss, you can catch our earlier episode about miscarriage. So, see you next week.
We're doctors.
But not your doctors.
Anything we've said in this video is for education or entertainment purposes only.
It is not medical advice.
Any specific medical questions you have should be directed to your provider.